Hello guys, this is Diogo Cherry-san. Today we're going to be talking about the spine, which is a huge subject for misconception. It's, in my opinion, one of the least understood parts of the body. Anderson, in his study, The Epidemiology of Spinal Disorders, said that spinal pain is the second most common reason for physician visits. And it's the fifth most frequent reason for hospitalization. The spine consists of 33 vertebrae stacked up, 9 of which are fused, which are the sacral and the coccygeal vertebrae, and then the rest of them move in a very complicated manner. It's very specific, but at the same time there are very simple points that I wanted to highlight here in this video, and you guys will understand a little more of spinal pain. So we're going to be talking about a few structures, so I wanted to highlight that where the nerve comes out in the spine, there's a little space comes out from the medulla through the lateral foramina. This that you're seeing here is the lateral foramina. This is the body of the vertebra. This is the spinous process, and we're going to be talking about some of these structures separately. This right here is the facet joint. Okay, the vertebra above has a little bony structure coming down, the vertebra below a little bony structure coming up, and these joints hold the spine from moving too much into extension, so as if you were bending backwards, and also from twisting motion, so you don't twist your spine, which is the central nervous system and is very, very delicate. Okay, so when you're standing straight, the intervertebral disc receives pressure that is equal to each side. The intervertebral disc has an annulus fibrosus that you can see here, which is a ring that works kind of a ligament. It's a stronger structure than the nucleus pulposus, what you guys are seeing here. It's more a jelly structure. So when all forces are pressing equally towards each direction, the discs tend to be healthy and not suffer too much stress on one spot, and you're pretty much avoiding a herniated disc. Now, what happened with forward bending, most people bend forward, arching their back forward, is that all the pressure in the disc comes to the frontal, squeezing the front and pushing all this content to the back. That's why discs herniate most of the time posteriorly. And this is the area of the disc, that it'll herniate, and then this part right here can press on the nerve. Okay, this is what everyone knows as herniated disc. Now let me take the chance that we're looking at this image to bust one myth. One of them. There are lots of them. Disc herniation is only a problem if the herniation or the content of the disc is pressing on the nerve root. Okay, you can see here the nerve root, again, coming out right here through the lateral foramina. It's right here, closely related, in close relationship with the intervertebral disc. And when it herniates, it can press against the nerve root. Now, if the herniated disc is pressing on the nerve root, the symptoms that the patient is going to have are called radiculopathy, which involves some loss of sensibility or loss of strength. Right here, we have the anterior nerve root and we have the posterior nerve root, and they both come in through here. So you could have actually separately, believe me or not, only anterior nerve root damage when you have a herniated disc, or a posterior nerve root damage. The posterior one is that causes the burning pain, the tingling, loss of sensation. The anterior nerve root causes weakness, and it can be very silent. So you're looking at a pelvis drop, a drop foot, and some gross weakness, in the cervical. So pretty much the myotomes. What's happening nowadays is that people go get an MRI done. They find out they have herniated disc, and a lot of my patients ended up in surgery. So years later, or they come, for rehab, post-surgical, but when we're interviewing the patient, they never had radiculopathy, which means that the herniation was asymptomatic. In our perspective, from a rehab perspective, you can do an MRI, and it has been done. You can MRI healthy patients that have absolutely no pain, and you will find herniated disc. That's normal. That's a common, normal finding on MRIs. It is only a problem if it's pressing on the nerve root. I wanted to show you guys the images, the biomechanics behind it. Everyone needs to be on board with it, because there are a lot of people freaking out finding herniated discs in their MRIs, and a lot of these people end up in surgery. Now, another point to make is when we're assessing the patient, most of the time these patients have pain on the back. Okay, so when you're bending forward, you're stretching the back muscles. Okay? When you're bending backwards, you're compressing the lateral foramina and the facet joints. So look at this little extension here, and look again in the spine, how that will close the facet joint. So this is the posterior side, okay? Posterior, and this here is the anterior. You can see the spinal processes here. If you start closing the side or arching even more, what do you think is going to happen to this lateral foramina? Squish. It's going to close. What do you think is going to happen with this facet joint here? Close. Have more pressure. Squeeze. So let me make it very simple for you guys. Pain with flexion is muscular. Pain with extension is in the joint. That involves other syndromes: anterolisthesis, retrolisthesis, spondylolisthesis, facet joint entrapment, lateral foramen entrapment, and many others. Pain with flexion is muscular. When you're bending forward and your spine hurts, and it's a diffuse long pain, so it's all throughout your spine, or it's like a long big area, your pain is muscular. A lot of these people, again, have their MRI results, and it really hurts when they bend forward, and they are really concerned that the disc is hurting them. So this is one of them that I was talking about. This is called spondylolisthesis. Spondylolysis, I just wrote on my Instagram page the difference. There's a huge misconception, like students just get a little confused sometimes. Spondylolysis is when the pars interarticularis break, it fractures. but there is no slippage. Okay, just the crack that you see here. It cracks, but there is no slippage. Spondylolisthesis is when there is slippage. So look at here, the vertebrae. This pars interarticularis works as an anchor. And when this anchor breaks, this whole higher segment of the spine is pulled forward. Okay? Usually because of the normal lordosis of the spine. It's more common in the lumbar spine. So with all the weight of the trunk compressing down, and then since the lumbar has this curvature, the lordosis, it pushes all the healthy segments forward, causing tension here in the spinal canal that is coming, which can cause myelopathy. So there is spondylolisthesis without myelopathy, so no radiculopathy, no nerve symptoms, just the pain. And there is spondylolisthesis with myelopathy. They're divided in 4 grades. Grade 1, 2, 3, and 4, depending on how much slippage there is related to the injury. Now let's talk about some syndromes that mimic nerve damage, which is another thing. A lot of people have actually the symptoms of a pinched nerve, a herniated disc, of a nerve damage. But what happens if they get operated in the spine, you are not going to fix the problem. They're not going to get the problem fixed. So the nerve, let's take the femoral nerve, corresponds to L2, L3, the innervation when you're checking the myotomes, or the sensitive part on the side of the thigh and the front of the thigh. It comes out of the spines and it crosses the iliac crest, and it can be pinched against the abductors muscles, and some soft tissue here can pinch the lateral femoral nerve. Okay, lateral femoral cutaneous nerve. It's very common with police officers because of the tight belt. It's common because of tight clothing, people that gain weight and they, still try to fit in the pants, or the pants are a little larger, so they put a real tight belt to be able to wear it. Whatever is squishing here on the side contributes to this syndrome. But also standing up for long periods of time, even though the patient is wearing loose pants, it can also cause myalgia peristatica. It mimics sciatica. You get tingling going down the thigh, just this lateral portion of the thigh. You can even have trophic changes in the skin, alopecia, some hair falls out. You can have a true loss of sensation that you will not get any response using anesthesiometer, but it's not sciatica. So what I'm showing here is the very compression to the nerve is happening here. The syndrome is called myalgia peristatica. Okay, if you operate on the spine, like I'm assuming it has happened in the past, I haven't seen myself, but I've seen so much already, that if they get operated in the spine, they're not going to get any relief to the pain or to the discomfort or to the pinched nerve. Okay, because the damage is happening outside of the spine in another side. Another example is the piriformis syndrome. So here you can see the piriformis muscle, and you can see how the sciatic nerve passes in this image underneath the piriformis, but actually spout holds. It's a German anatomist. He says that the sciatic nerve can go from above the piriformis through the piriformis muscle, or from below the piriformis. In this image is below. When this piriformis gets into a spasm, it causes what we call piriformis syndrome. Patient has shooting down the pain all the way down to the bottom of the foot, okay, all the way down. Again, with the same example, you may not find any problem, any dysfunction in the spine. So that syndrome mimics sciatica, nerve damage, okay? This is an image from De La Viere biomechanics, anatomy of exercising, and I just wanted to highlight how this hyperextension, back to what I said in the beginning of the video, that this hyperextension is a little exaggerated. So I disagree with the posture of the models in this book, because you're compressing too much the facet joints, closing too much that lateral foramina, and you're causing too much stress on the, pretty much pushing the content of the disc anteriorly and compressing all these structures on the back, okay? So for you guys watching the video that squat, or you have your patient squatting for strengthening, deadlifting, your abs have to be really tight, pushing against the vertebrae to find a more neutral position, not an anterior pelvic tilt like you're seeing here, a more neutral one. So bring the pelvis a little back in posterior pelvic tilt and put the spine in a more straight position. That's what I would recommend to De La Viere, okay? Arching the back too much doesn't protect your back. Some people know that the rolling forward, bending forward is bad. I completely agree, but this hyperextension is not constructive at all. Last phase of rehab is always strengthening, aggressive strengthening, plyometrics, especially for the spine. You have to change the ergonomics, your work posture, your studying posture, your lifting posture. Make sure you watch your patients, you change, you help them to understand the biomechanics. Not bending forward too much, not bending back too much, finding more a neutral position and really activating your abs. We're gonna be talking more specifically about the rehab, the different phases, different exercises in another video. Thank you guys so much. Stay tuned. If you haven't subscribed to this channel, click subscribe and like this video so YouTube can send you more of the same. Thank you so much.